Hello, welcome back to my channel. My name is Michelle. So this is part 2 of severe acute malnutrition. So in this video, we'll discuss the 10 steps of managing a patient with severe acute malnutrition. So the 10 steps of managing patients with severe acute malnutrition are as follows. The first one is to treat and prevent hypoglycemia. The second one, treat, prevent hypothermia. Then the third one, treat, prevent dehydration. Number 4, we have to correct the electrolyte imbalance. Number 5, we'll treat and prevent infection. Then number 6, correct malnutrition deficits. Then number 7, we'll start cautious feeding. Then number 8, we'll achieve catch-up growth. 9, provide sensory stimulation and emotional support. Then the last one, prepare follow-up after recovery. So in this video, we'll discuss these 10 points in details. So before we discuss these 10 steps, there's a time frame in which all these steps need to be started, done, and stopped. So the first one, which is hypoglycemia. This one, you need to do it as quickly as possible. And then the last one, which is preparation for follow-up, this will be done in the last phase. Now, there's a time frame which all these steps have to be done. So the table here is showing that from day 1, when you first see and diagnose this patient to have severe acute malnutrition, to week 6, the patient has to recover and you need to discharge this patient. So from day 1 and day 2, we're going to treat hypoglycemia, then hypothermia and dehydration. So in the first 2 days, we need to make sure we correct these 3. But remember, there are some other steps that we'll start them on day 1, but will take about 2 to 6 weeks to control these imbalances. But for hypoglycemia, hypothermia, and dehydration, you need to correct these within 2 days. Then for electrolytes, this you need to correct it continuously for the whole 6 weeks. So you see, gradual correction. You take longer collecting this imbalance, but for hypothermia, dehydration, and hypoglycemia, you need to correct them very quickly within 2 days. So if the patient comes in, the patient is hypoglycemic, you need to control the blood sugars within 2 days. Then we come to infections. Infections needs to be corrected within 7 days. So a patient comes in day 1, you discover this patient has infections. You give antibiotics. Within 7 days, you have to clear that infection. So that's the target. And then micronutrition. So in this one, from day 1 to day 7, you're not going to give iron. But after week 2 to week 6, that's when you start supplementing with iron. After you have cleared the infection. Then cautious feeding. You need to feed cautiously within the first 7 days, because you're trying to avoid refeeding syndrome. Then after cautious feeding, after 7 days, That's when now you start catch up feeding. After you have now corrected the the other problems that the patient has, and after you have fed cautiously, and you know that the patient has now uh, been moved out of a situation where they can have a feeding syndrome. That's why now you start catching up feeding. Then you do sensory stimulation. So sensory stimulation starts from day one up to the day of discharge. That's after 6 weeks. Then preparing for follow-ups, you start after 2 weeks. So now you start preparing this patient for follow-up or discharge. So we are managing the hypoglycemia in the first step. So hypoglycemia in malnourished kids is less than 3 millimoles per liter. So if the child can drink, we are going to give this child the oral. So we are just going to feed this child the needed the glucose. So in this case, we are going to give 50 mils bolus of 10% dextrose oral. So you can get a syringe, feed the child slowly until that 50 mils is consumed by the child. If the child is alert but not drinking, we give the 50 mils by NG tube. So remember that we discussed in the previous video ways in which we can administer or give food to these children. We talked about the nasogastric tube. So this is where it also comes in. So the child is alert but is not able to drink, so we insert the NG tube. Then we feed. So in a case where the child is lethargic, unconscious, or convulsing, we're going to give IV. So in this case, we're going to give 5 mils per kg body weight of 10% glucose by IV. Then we're going to follow it with the 5 mils, 50 mils of 10% dextrose by NG tube. If the IV dose cannot be given immediately, we can then give the NG dose first. So in this case, we are dealing with a child who is unconscious. This is why we're going with the IV route. And then after that, when the child regains consciousness, is able to feed, we can start the child on F75 after an hour after giving glucose during the first 2 hours. So we have a child who is unconscious. We give the 50 mils, 5 mils per kg IV, 5 mils per kg IV. Then the child, then we put an NG tube. Then we can also give 50 mils of 10% glucose via NG. Then, if the child gains consciousness, is able to feed, we'll start feeding with F75 an hour after giving the glucose during the first 2 hours. So you can start feeding this child after 1 hour. Of course, you continue monitoring the blood sugars. Then if the child's blood glucose is not low, begin feeding the child with F75 right away. So the glucose was just trying to control the hypoglycemia. But if the child is not hypoglycemic, we can go direct to feeding the child with F75. So these are just formulas or food packages. I'll show you some pictures and what they contain. They contain a lot of nutrients, proteins, carbohydrates in certain ratios. So we start with F75. So we feed the child every 2 hours, day and night. So you start feeding the child, let's say around 10 hours. You feed at 12 hours, you feed at 14, 16, 18, until 24. Whether the child is asleep, you wake the child up at 02, at 04. So you feed the child day and night. Whether the child is asleep or not, we continue feeding every 2 hours. The second step, we are treating the hypothermia. So this child is feeling cold, the body temperatures are dropped. So when you do the rectal body temperature, if it's less than 35.5, then we consider this child to be in hypothermia. But even in a case where the temperature is maybe 36, we just have to keep this child warm so that we prevent hypothermia. So we are treating and preventing. So even if the temperature is 35.8 or 36 degrees Celsius, we're still going to prevent hypothermia by giving the child warm clothing, providing a heat source, provide warm skin contact or a heat converter. So the instances where maybe the child is small enough to be put on the mother's chest, so you can ask the mother to put the baby on her chest and then cover the baby so that there is that heat exchange between the mother and the baby. Then we avoid rapid rewarming as this may lead to disequilibrium. So we need to warm these children slowly. Then always we feed immediately. So feeding just has to be one of the first things that you do. Then on prevention, we're going to put these beds away from drought areas. So where there's an open window, we close the window, or we put the baby where there's the windows are closed. Then always keep the child covered. Then as usual, feed the child every 2 hours, day and night. Then step 3, dehydration. So dehydration is very hard to detect in these children, but there are few signs that are reliable for detecting dehydration. So first one is history of diarrhea. So remember you clicked this patient, you took a good history, they told you know this baby was having frequent diarrhea. So you know that diarrhea causes dehydration. So this child is most likely dehydrated. The child is thirsty. Recent development of sunken eyes, weak or absent peripheral pulse, cold arms and feet. So these will show you that the child is dehydrated. But the most important one is low urine flow. So you can catheterize this child, or you can check the diapers. So you find that you ask the parents before you start treating the child. So you need to expose, remove everything that the child is wearing. You give the child the new clothes, clean clothes. But as you remove, you check that the diaper is not wet. Then you ask the mother, when did you change this diaper? Then they tell you that this diaper has been there for several hours. So you pick that obviously this child is dehydrated. You put another diaper. You check after 2 hours, there's still no urine. There's a high chance that this child is dehydrated. So urine output is very important to detect dehydration. Even shock, you can use urine output to detect if the patient is in shock. So, what do you do to treat this dehydration in these kids? So, you have seen that the child is dehydrated. So, you give fluids. So, the kind of fluids that you give in minority kids is called rhizomo, rehydration solution for malnutrition. So, this is specifically for pediatrics or malnourished. So, you give 5 ml per kg every 30 minutes for 2 hours. Then you reassess the child and you weigh the child. So you're weighing the child to avoid the fluid overload. So remember, you weighed the child the first time you started interviewing and collecting this patient. So you already have the weight. So if you're giving fluids 5 ml per kg every 30 minutes for 2 hours, you need to see if the child is able to absorb and excrete some of this water so that the child does not go into fluid overload. So, if the child is stable, you can, as usual, initiate feeding with F75. Then, you feed at 10 ml per 10 ml per kg and alternate with the rhizome at 10 ml per kg for every hour for up to 10 hours. So this is the child who is stable, so your found is not dehydration. You just continue feeding. Then of course you can also alternate with the rhizome. But if the child is dehydrated, quickly go for rhizome at 5 ml per kg every 30 minutes for 2 hours. Then you reassess. Remember, when you're reassessing, you need to check the lungs. They have fluid overload in the lungs. So you check all those things, check the weight to avoid the overload. You also measure the circumference of the abdomen, because when you have fluid overload in these kids, the liver can absorb most of this water, these fluids, and can enlarge. So when you measure before feeding this fluid, and then the child has taken a lot of water, some of it will be lodged in the liver, and the liver will expand, hence the circumference of the abdomen will increase. So you can also use that to check if there's fluid overload. So we'll move on to step 4. So we will discuss it together with step 6. So step 4, we are treating and preventing electrolyte imbalance. So the feeds F75 and F100 and fluid rhizome are fortified with electrolytes and micronutrition in adequate proportion. So again, the treatment and prevention of micronutrition, which is step 6, will also be controlled by these feeds in combination with the rhizome fluid. Move on to step 5, where you're treating and preventing infections. Remember, when you're giving fluids, you discover that this child had a shock which was not resolving using fluids. So the child was just getting overloads. You suspected the infection, septic shock. And remember, you did some infection screening, which were discussed in the previous video, the part 1. We did some septic screening where we checked the urine, we checked the blood, we checked a lot of sites for infections in order to prepare ourselves to manage these infections. So if you found that maybe the child had the UTI, you start managing that UTI. So in this case, Give all patients with severe acute malnutrition antibiotics for presumed infection. So after you get all those labs, the blood, you take for uh, lab or culture. You start them on broad spectrum antibiotics because you are presuming that they have infection. Once the results are back, you can now get that infection. So if the child has no complications, you can give oral antibiotics. If the child has complications, you can give IV broad spectrum antibiotics. Then we move into step 7, feeding formulas. What are F75 and F100? So we've talked about F75 a lot, F100. Now what are they? So in step 7, where you're doing the cautious feeding, this is why you have these formulas or these feeds, this food. So F75 is the starter formula to use during initial management, beginning as soon as possible and continuing for 2 to 7 days until the child is stabilized. So this F75 is a diet that is low in proteins and sodium and high in carbohydrates. So we are supplying a lot of energy. This is what we have a lot of carbohydrates. Remember, these first 7 days, the child is usually in hypoglycemia. This is why we are controlling this hypoglycemia in the first 7 days. No wonder we also have this feed, which is also high in carbohydrates. Supplement that deficiency in energy. So this F75 has got 75 kilocalories and 0.9 grams of protein per 100 meals. So how are we going to determine the frequency and the amount of feed? So feed orally using NG tube if the child does not take 80% of the feed. So you try to feed the child with a spoon. In that bowl that you have prepared, the child is only able to take 20%. That 80%, the child is not eating anything. It's refusing to eat. That 80%. So the child does not take 80% of the feed or leaves more than 20% for 2 or 3 consecutive feeds. Then you can give using NG tube. So in short, the child is not taking enough. The goal is to feed the child a lot of this formula. But you prepare the formula and the child is only taking about 20%. The other 80% is remaining on the bowl. You switch to NG tube so that you can feed the child enough. So you remove the NG tube when the child takes 80% of the dairy amount orally or 2 consecutive feeds, full by mouth. So now you can switch from NG tube to oral if the child is able to take 80% of the feed. So on the first day, you're going to feed the child a small amount of F75 every 2 hours, 12 feeds in 24 hours, including through the night. So this is the frequency of how you're feeding this child. Every 2 hours, day and night. So in total, you're going to feed this child 12 times in 24 hours. From 8 hours to the following day 8 hours, you're going to feed this child 12 times every 2 hours. So if the child is hypoglycemic. How are you going to feed this child? So you get a quarter of the 2 hour amount every half an hour for the first 2 hours until the child's blood sugars are at least 3 millimoles. So when you did the random blood sugar, you discovered the child is in hypoglycemic. You gave the dextrose and so on. Now you have moved to the feed. How are you going to give a feed in a child who is hypoglycemic? So you get that pack, you get what you're supposed to give that child in 24 hours. Then you get that feed that you want to give in the first 2 hours. Remember, we're giving these kids the first 2 hours. Every 2 hours, every 2 hours. So you get that feed, you give a quarter of the 2 hour amount every half an hour for the first 2 hours. So just get that feed you're supposed to give every 2 hours. So you start at 10 hours. So you get that feed for 10 hours. You break it down into 4 parts. Then you're giving every 30 minutes. Every 30 minutes. Until that 2 hours is complete. So it's different with where the child is not hypoglycemic. You give at 10 hours, then you stop. You wait for another 2 hours. So at 12 hours again you give. But in this case, you are trying to correct the hypoglycemia. So you'll be giving every 30 minutes. But you're not going to give the whole amount. So you're getting that 2 hours feed that you're supposed to give in 2 hours. Divide it into 4 parts. Then you're giving every 30 minutes. So that feed for 2 hours, you break it into 4 parts every 30 minutes. As you're going to be until the sugar is at least 3 millimoles per liter. After the first day, increase the volume per feed gradually so the child's system is not overwhelmed. The child will gradually be able to take large, less frequent feeds every 3 hours or every 4 hours. So we are trying to determine the frequency. We discussed about how you can use this feed to correct the hypoglycemia, where you're giving a quarter of what you're supposed to give in 2 hours every 30 minutes. Now, you are giving a small amount of this feed in this 24 hours. So you're just giving small portions every 2 hours. But with time, you can now start giving larger feeds. So you're going to increase it from 2 hours to 3 hours because the child is eating enough, is eating in large portions. So you increase the time when you feed this child from 2 to 3 hours. So this increase is done after a day. Remember, the child has to be able to feed about 80% of the feed. The child is able to eat 80% of the feed that I've prepared. The child is not hypoglycemic. You already started the antibiotics. You're given the fluids. All those were started on the same day, at the same time. So now we're trying to adjust the feed. So in the first day, when you collect these things, and then the child is able to eat, you can increase the amount of the feed. So let's say, for example, in day one, you are giving this child maybe 5 spoons of this feed every 2 hours. Then on day 2, you can increase this 5 spoons to maybe 8. Instead of giving every 2 hours, you can increase to every 3 hours. So, so you need to be cautious when you're increasing or decreasing this feed. So here are some of the criteria that you can use to increase or decrease this feed. So if little or no vomiting, modest diarrhea, for example, less than 5 water stools per day, and finishing most of the feeds, change to 3-hour feed. Like I had said before, the child is able to eat most of the feed. The child is not vomiting or is vomiting little as modest diarrhea, less than 5 water stools per day. Then you can increase the feed and the hours, the period you are giving these feeds. So from 2 hours, you can increase to 3 hours. After a day or 3-hour feeds, if no vomiting, less diarrhea, finishing most of the feeds, change to 4 hours. So you are changing to 4-hour feeding. So on day one, the child is feeding poor. You stick to 2 hours. But let's say on day two, the child has improved. Is not vomiting, is eating most of the feed, 80% of the feed, has less diarrhea. You can increase the feed and increase to 3-hour feedings. If a day of this 3-hour feeding has passed and the child is not vomiting, less diarrhea, and finishing most of the feed, you can increase it to 4 hours. So increasing these feeds is basically dependent on whether the child is feeding 80% of the feed, is not vomiting, or has little vomiting, has less than 5 water stools per day. Then you can increase these feeds. So you can increase day 1, 2 hours, day 2 you can increase them to 3, then day 4 you can increase them to 4 hours, or every 4 hours. So we go to step 8, which is the catch-up growth. So as soon as the child stabilized on F75, you switch to F100. So this F100 is used as a catch-up formula to rebuild wasted tissue. So F100 contains more calories and proteins, 100 kilocalories and 2.9 grams proteins per 100 meals. So F75 is basically for energy. It has more energy, enough to remove this child from this hypoglycemic state and stabilize this child. And then F100 has even more, especially on the protein side. There's more protein for bodybuilding. Now you want to start repairing and building this child. After I've stabilized this child using F75, you now want to start rebuilding this child. So you're rebuilding all the muscles. You want to restore the storage of the glucose, the fats. So in short, it's now a catch up. The child needs to catch up to the norm standard. And they're giving this F100, which has more of these proteins and the calories. So when to adjust this F100, so you're going to look for signs of readiness, usually after 2 to 7 days. So you feed the child on F75 from day 1 to day 7. Then during this period, from day 1 to day 7, or from day 2 to day 7, you're going to look for, as the child's appetite retained. So the child is easily finishing 4-hour feeds of F75 So the child is able to eat about more than 80% of those feed. The diarrhea is reduced. The child has good appetite. The child is willing to feed. You have stopped using NG tube. The child is eating well. Then the child has also reduced edema or minimal edema. Then you can now upgrade to F7, F100. So minimal edema or reduced edema, return of appetite. So the child is able to feed using the 4-hour feed of F75. So every 4 hours the child is able to eat properly, this F75. Then you can change to F100. So during this period, the child will even show some improvement. The child will be able to smile, be more active, able to engage with the people around. Because remember, this 2 to 7 days, so this first week, you are giving this child enough energy. So now the body is functioning better than before. So you're going to see some improvement. Then you can now change to F100 so that you can now build the muscles, supply more energy for this growth and repair of the body. So this is a table just showing the contents or the constituents of this F75 and F100 was found in both. So the rate of minerals there and the energies and proteins, even some fats also there. So how you give this F100? So you give it slowly and gradually. So you're going to transition in 3 days. So the first 2 days of giving this F100, you give it every 4 hours in the same amount as you give the last F75. So let's assume you're giving this child the F75, you're giving this child 10 spoons. Now you want to change to F100 because there's minimal edema, able to finish the feed, appetite has retained. So you're going to continue giving those 10 spoons now of F100. You give the spoons to the child, those 10 spoons for 2 days. So the amount remains the same, but the formula changes. On day 3, increase each feed by 10 meals as long as the child is finishing the feed. So now you can increase by 10 meals. So add more feed. Then you continue increasing the amount until some food is left after most feed. Usually when the amount reaches about 30 meals per kg per day. If the child is breastfeeding, encourage the mother to breastfeed the child between feeds of F100. So you continue increasing the amount of feed until the feed left is little. So in short, remember the child's appetite has retained. So now, and the child is slowly becoming alert and more responsive. So you can continue feeding the child. Of course, every 4 hours. But you can be increasing the amount of feed until you reach a point where the child is taking 300 meals per kg. Then if the child is breastfeeding, you can also encourage the mom to breastfeed the child during those periods. So you feed that 4 hours, so you feed that 10 hours. The next feed will be at 14. So during this gap, you can encourage the mother to breastfeed the child. So as you continue the feeding, the catch-up feeding, and the initial feeding, you can now give. You can also give ready-to-use therapeutic feed. which is shown on this picture. It can also be used as a catch-up feed. And then you need to monitor the patient's progress and care. So, good weight gain. A child should gain 10 grams per kg per day. So expect a child to be gaining 10 grams per kg per day. So let's say, for example, the child is 10 kg. You weigh the child on the first day, the child was 10 kg. You expect the child to gain 100 grams in one day or more. That's good weight gain. Then moderate, it's up to 5 to 10 grams per kg per day. Then poor weight gain, the child is gaining less than 5 grams per kg per day. So you can also use this to see if your treatment and management is working. So the child should begin at least more than 10 grams per kg per day. And then you go to step 9, where you are providing sensory stimulation and emotional support. So this one is straightforward. So you have a stimulating environment, in a cheerful environment. If you have noticed in pediatric wards, the walls are painted with cartoons and so on. You can give them something to play with, and watch a movie, a cartoon, or something like that. That will help the child mood improve. Step 10, where you are preparing for follow-ups. So in this one, you need to check for primary and secondary failure to response. So now you want to check if your child is ready to be discharged. So under primary, failure to respond is indicated by the child's failure to regain appetite by day 4. So if you have been managing this child, but you're seeing that by day 4 the child is not gaining appetite, and the child is not responding. Presence of edema on day 10. So you see that the edema is not improving, meaning the child is not responding. And failure to gain at least 5 grams per kg per day by day 10. This will show you that there's a failure to response of what you're managing this patient. So I'm sure the patient is not improving. So by day 10, expect the child to have at least more than 5 grams per kg per day weight by day 10. The presence of edema should reduce, and the child should be able to gain appetite by day 4, meaning the child is improving very well. Anyway, if the child is not meeting any of these, meaning the input is poor. Then secondary failure to response is indicated if there's failure to gain at least 5 grams per kg per day for consecutive days during the rehabilitation phase. So after a week or 2, the child has failed to gain 5 grams per day per kg, even the secondary failure, which means ensure the child is not improving. So remember, we had done a full blood count. So if I tell the child is anemic, so the child has anemia, moderate or mild anemia. It's usually common in severely malnourished children and should be treated later with iron after the child has stabilized. Remember, there's the first chart that we had seen where it was indicated that under nutrition, in the first 2 weeks, you are not able to give iron. So even when the child is anemic, we are not going to give the child until the child has stabilized. If anemia is very severe, you need to give blood. So how we're going to do this? If the HB is less than 4 grams per ml, or the packed cell volume is less than 12%, we won't give blood transfusion. If there are no signs of congestive heart failure, transfuse all fresh blood at 10 ml per kg slowly over 3 hours. So check this child has no signs of heart failure. Then you can transfuse blood at 10 ml per kg slowly for a period of 4 hours or more, or 3 hours or more. Then you continue. If there are signs of heart failure, so you check your signs of heart failure. You give 5 to 7 ml per kg of packed cells over 3 hours instead of whole blood. So this time we're giving packed cells, not whole blood. On top of that, you give diuretic so that you avoid fluid overload. So this diuretic will pour out excess fluid because the child has signs of heart failure. Then this fluid you give is this drug you give is furosemide. It's a diuretic that you give at 1 milligram per kg. You give it IV. So after correction of all those complications that the child may have had, with good appetite, it's time to discharge this patient. So when discharging this patient, there are some general instructions that you give to the parents or the family. So in addition to feeding instructions, mothers will need to be taught that, so you explain how you're going to be feeding the child. You explain if at all the child has got any signs of infections, what the mother should do so that the mother can quickly come back to the clinic. You explain the nutrition, you explain the condition that the child had and what you have done for the child, and then you make sure that you educate the parents on the medication that you give them as you're discharging them. So you can give them iron to give for 1 month at home. Then they can continue vitamins. You can give them some vitamins. You should continue giving the child vitamins, folic acid for at least 1 to 2 weeks. And then you plan for follow-ups. So they need to come back for reviews. So reviews will be checked at week 1 after discharge. So you discharge the patient on day 20, on 20th, on 27th, they need to come for review, for checkup, so that you can reassess the child, check if there's any improvement. After that, you increase to 2 weeks. So they increase to 2 weeks. 2 weeks will pass, then they'll come. Then after that, you increase to a month, then 3 months, then 6 months. And then twice every year until the child is at least 3 years old. So you can continue twice every year for checkup for at least 3 years, or when the child is 3 years. So this is where we end this presentation, part 2, which is management of severe acute malnutrition, the 10 steps, and a few things that you need to do in each step. Thank you.